So are you ready? Should we start?
Yes, sir.
Right. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 16B, which is Hematology Non-Neoplastic Lesions of WBC. We are streaming live from IPGMER, Kolkata. And today's topic is non-neoplastic lesions of white blood cells. This is session 2, where will be Dr. I think she doesn't need any introduction. She is a real hit on the net. She's an MBBS honors with gold medal, with MD Pathology honors. Presently she's a demonstrator in IPGMER and SSKM Hospital, Kolkata, with areas of interest in cytopathology, hematopathology, and oncopathology. A very excellent speaker and with profound knowledge. So before I ask Dr. Shristi to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request, ma'am, please share your screen and let's start.
Thank you so much, sir, for such an introduction. I don't know whether I deserve it or not. Thank you so much. So is it visible?
Yeah, just press that hide pop-up, it will go away. Yeah, please start. Thank you.
Thank you, sir. So very good evening to everybody. We are all set to start with neutrophils and its non-neoplastic disorders, session 2. The neutrophils are phagocytic granulocytes that constitute an important component of the rapid, non-specific immune defense mechanism. They, like other leukocytes, are derived from the pluripotent hematopoietic stem cells. A total absence of neutrophils or a significant decrease in their number leads to severe immunodeficiency. Now, immunodeficiency due to an inborn absence or a significantly decreased number of neutrophil granulocytes results in an unusually severe course of an infection by an unusual pathogen, sometimes resulting in a recurrent pyogenic infection and recurrent infections of the upper and lower respiratory tracts. So, in this lecture for today, we have the non-neoplastic disorders of the neutrophils. First among is, let me just show it to you, is the WIM syndrome. Okay, now this WIM syndrome basically arises due to the emigration defect of the neutrophils from the bone marrow. Subsequently, we have the quantitative defects, that is the severe congenital neutropenias and cyclic neutropenias, which will be discussed just in a bit, and the chemotactic defects, which includes the leukocyte adhesion defects 1, 2, 3, autosomal dominant hyper IgE syndromes, and the Shidiak-Higashi syndrome. Besides that, we also have the bacterial killing defects like the chronic granulomatous disease and G6PD deficiency. So the entire seminar will be around these disorders, and there will be disorders resulting in neutrophilias and neutrophil function defects. Now, coming to the disorders of the neutrophil number. Neutropenia is an absolute reduction in the number of neutrophils. This neutropenia can either be mild, moderate, or severe. When it's mild, it ranges from 1000 to 1500 per microliter, whereas moderate neutropenia ranges from 500 to 1000 per microliter. Severe neutropenia results when the absolute neutrophil count is just less than 500 cells per microliter. Now coming to the causes of neutropenias, right? There are several that you can see. You have congenital causes, failure of production from the bone marrow, severe chronic neutropenias, cyclical neutropenias, and reticular dysgenesis. There are syndromic disorders associated with neutropenias like the glycogen storage disease type 1b. We also have the Sherman-Diamond syndrome, cardioskeletal myopathies, and onychotrichodysplasias. Antibody-mediated neutropenias can either be autoimmune or alloimmune neonatal neutropenias. Neonatal neutropenia due to autoimmune diseases in the mother is also one such. Idiopathic causes includes the chronic benign neutropenias. Now moving on to the benign neutropenia of infancy. The presence of maternal alloantibodies which have passed the placenta and are directed against the epitopes on the child's neutrophil is a common cause of neutropenia presenting in the first month of life. Also, in early infancy, there are some autoantibodies directed against the neutrophilic antigen 1 and 2 epitopes on the surface of the neutrophils. These can lead to destruction of the neutrophilic precursors and thus cause neutropenia. Because of the often mild and transient course of this disease, it is referred to as the benign neutropenia of infancy. The disease recovers spontaneously, usually within 3 years of age. The next slide is on severe congenital neutropenias. Now there are 4 types. One is the severe congenital neutropenia type 1, where the defect lies in the ELANA gene. Okay, it is an autosomal dominant disorder and usually presents with the chronic or cyclical neutropenia. Whereas type 2 results from a defect in the GFI1 gene. The functions of these genes will be discussed in the subsequent slides. This too is an autosomal dominant disorder and presents with neutropenia together with lymphopenia. Severe congenital neutropenia type 3, also known as the Costman syndrome. Yes, it arises due to the mutation, rather inhibitory mutation in the HAX1 gene. It's an autosomal recessive disorder and patients usually present with neutropenias. On the other hand, we have severe congenital neutropenia type 4, where the defect lies in the glucose 6-phosphatase catalytic subunit 3. This is an autosomal recessive disorder and patients present with neutropenia together with thrombocytopenias. Now let's go into it one by one. Now children with severe congenital neutropenias are characterized by an early onset of life-threatening infections. As we all know, any severe persistent neutropenia can result in a life-threatening infection. There's a maturation arrest typically happening at the myelocyte and promyelocyte stages, right? And the most common cause of severe congenital neutropenia is the mutation in the ELANA gene. This ELANA gene is typically very important. It's an autosomal dominant mutation, and the gene that you're talking about, that is the ELANA gene, is also mutated in cyclical neutropenias. Now, what are cyclical neutropenias will be discussed in just a bit. But before that, what is this ELANA mutation? This ELANA mutation is very important because this ELANA gene has a role in elastase production. Now, what is the role of the neutrophil elastase? Neutrophil elastase is very important because it helps in maintaining the normal function of the endoplasmic reticulum of the myeloid precursor cells. So any defect in this elastase would result in early apoptosis of neutrophils and subsequently a neutropenia. Besides the severe congenital neutropenia type 1, we also have type 2. In type 2, there is a defect in the GFI1 gene, and that is implicated in the normal neutrophilic hematopoiesis. So mutation GFI1 calls for an abnormal neutrophilic hematopoiesis. Moving on further, we have the severe congenital neutropenia type 3. This type 3 is also referred to as the Costman syndrome. Now, what is this Costman syndrome? It's an autosomal recessive disorder and caused by mutation in the HAX1 gene. Now, what is this HAX1 gene? As we all know, HAX1 is a major inhibitor of neutrophilic apoptosis in the myeloid cells. So, if there's a defect in the HAX1 gene, there's an accelerated apoptosis of the neutrophils, resulting in neutropenias. We also have the severe congenital neutropenia type 4, where there is a defect in the glucose 6-phosphatase catalytic subunit 3. Patients with mutations in G6PC3 or glucose 6-phosphatase catalytic subunit 3 suffer from a myeloid maturation arrest, usually at the myelocyte or promyelocyte stages, and that results in a congenital neutropenia. Now, what are the investigations that you can do? If there is an absolute neutropenia, usually presenting at the first day of life, okay, and the counts are below 200 per microliter, a bone marrow examination in such a case would just reveal a myeloid hyperplasia with maturation arrest at the myelocyte or the promyelocyte stages. Bone marrow culture shows that the precursor stem cells in the bone marrow are capable of proliferating with colonies of normal size and number, but these do not usually form mature neutrophils without an exogenous GCSF. So, such patients, if treated with GCSF, could have a very prominent survival of their neutrophils. Unfortunately, however, a long-term treatment with GCSF can result in leukemias, especially the acute myeloid leukemias. So that calls in for hematopoietic stem cell transplantation. Now, moving on, what is this emigration defect that we were talking about? That is the WIM syndrome. Now, WIM syndrome results from a typical mutation, which is an autosomal dominant gain of function mutation in the CXCR4. Remember, last time in session 1, when we were discussing neutrophils, we said that neutrophils, or the precursor cells in the bone marrow which express CXCR4, are retained by the bone marrow. So, CXCR4 expressing neutrophils are retained by the bone marrow because of their hyperresponsiveness to the ligand, that is, the stromal derived factor 1. Now remember, when we are talking in section 1, we said that the stromal derived factor 1 is implicated in the retention of the neutrophils in the bone marrow. CXCR4 expressing neutrophils are retained in the bone marrow because of the expression of the stromal derived factor 1 by the bone marrow stromal cells and osteoblasts. And that results in a decreased motility of neutrophils, resulting in what is referred to as the emigration defect. This emigration defect allows for presentation in the form of warts or hypogammaglobulinemia and recurrent bacterial infections, as well as myelokathexis. Now, what is this myelokathexis? It's a form of neutropenia caused by an abnormal retention of mature neutrophils in the bone marrow. So, even though the neutrophils are mature enough, unlike severe congenital neutropenia, where there was myelocyte and promyelocytic arrest, WIM syndrome causes production of mature neutrophils. However, these mature neutrophils are retained because of the expression of CXCR4. Now, coming to reticular dysgenesis. Now, this is a rare condition characterized by congenital agranulocytosis, lymphopenia, and a lymphoid and thymic hypoplasia, resulting in a severe combined immunodeficiency. So besides neutropenia, there is also lymphopenia. However, the hemoglobin and platelet counts are normal. The bone marrow examination shows a pronounced hypoplasia with absence of the myeloid and lymphoid precursors. Mutations in the gene encoding the adenylate kinase 2 have been implicated in this disorder. So what is this adenylate kinase 2? This adenylate kinase 2 is a very important gene, the deficiency of which is associated with an increased oxidative stress and production of reactive oxygen species, a disruption of the mitochondrial membrane potential, and cell death. The severe neutropenia of reticular dysgenesis is, however, non-responsive to GCSF. Unless treated by hematopoietic stem cell transplantation, the disease becomes rapidly fatal. Now moving on to cyclical neutropenias. Now, this is a very rare disorder characterized by regularly recurring symptoms precisely due to neutropenias. Patients present with fever, malaise, mucosal ulcers, and occasionally life-threatening infections related to regular cyclical fluctuations in the number of blood neutrophils. It has an autosomal dominant pattern of inheritance. The condition is caused by a cyclical oscillation in the bone marrow production and release of mature neutrophils. Now, why does that happen? The reason behind it is the mutation in the gene encoding for neutrophil elastase. That is, remember the elane gene that we talked about in severe congenital neutropenia type 1? The elane gene was implicated in the production of neutrophil elastase. So mutation in the gene encoding for neutrophil elastase can also cause cyclical neutropenias. The condition is, however, caused by a perturbed interaction between elastase and serpins. Now what are these serpins? Serpins are molecules which interact with the neutrophil elastase, and that affects the timing of the biological clock governing hematopoiesis. So any problem in this clock results in a cyclical oscillation of these neutrophils, and their release from the bone marrow is, however, disturbed. Now coming to the antibody-mediated neutropenias. Now there are two types, one of which is autoimmune neutropenia of infancy, and the other one is the antibody-mediated neutropenia that occurs in the neonatal period. Now, autoimmune neutropenia of infancy is the most common cause of chronic neutropenia in childhood and is characterized by the presence of anti-neutrophil antibodies. So the autoantibodies can mediate a peripheral destruction of neutrophils and or inhibit its myelopoiesis in the bone marrow. A positive antibody test is very important, or rather crucial, because that can make a bone marrow biopsy completely unnecessary. Bone marrow examination in this case would therefore reveal a normocellular or hypercellular marrow with a myeloid hyperplasia, and there is production of autoantibodies which can be detected. Immune neutropenias in the neonate. Now, neutropenias in the neonate may be caused by an anti-neutrophil antibodies that are transplacentally transferred. Maternal anti-neutrophil antibodies may be present in conditions like autoimmune disorders, SLE, rheumatoid arthritis, or might be the result of prenatal maternal sensitization by fetal neutrophils. That is the alloimmune neonatal neutropenias. In alloimmune neonatal neutropenias, the antibodies are most commonly directed against the neutrophil antigen 1 or 2 epitopes. Such antibodies can remain detectable in the infant for up to 6 months. The diagnosis, however, is confirmed by the demonstration of these by anti-neutrophil antibodies both in the baby and in the mother. Now, chronic congenital neutropenia in association with other syndromes, like the glycogen storage disease type 1b, which is similar to the von Herx disease. We also have the Sherman-Diamond syndrome, which is an autosomal recessive disorder characterized by pancreatic insufficiency and neutropenias. The absolute neutrophil count in this case ranges from 200 to 400 per microliter. Other disorders like cardioskeletal myopathy and onychotrichodysplasia have also been reported. Now moving on quickly to neutrophilias. Now what are neutrophilias? You already know neutrophilia is best defined as an increase in the absolute neutrophil count that is above 2 standard deviation above the mean for normal adult individuals. So anything above 7,500 per microliter in adults is referred to as neutrophilia. In normal individuals, the neutrophil count varies with the serum cortisol level. Remember the one we discussed in the last class, that serum cortisol results in a decreased level of L-selectin. A decrease in the L-selectin results in inhibition of the rolling, and therefore neutrophilias happen because the neutrophils move from the marginating pool to the circulating pool, and that happens usually late in the afternoon under normal conditions. Neutrophil count increases slightly after meals, even with postural changes and with stress and emotional stimuli. So now coming to the workup of neutrophilia. The evaluation of neutrophilia begins with a thorough history and physical examination to search for an underlying disease state. Neutrophilia commonly results from an acute or chronic inflammatory process. A bone marrow examination is rarely required to ascertain neutrophilias. However, if you're suspecting a primary marrow dyscrasia, it is often required. Bone marrow biopsy with culture usually detects fungal or mycobacterial organisms. Now coming to the major causes of neutrophilia, you have the primary causes like the hereditary neutrophilias, Down syndrome associated neutrophilia, typically the transient myeloproliferative disorder or the transient abnormal myelopoiesis, leukocyte adhesion defects, chronic myeloproliferative disorders, and reactive or secondary neutrophilias typically occurs due to acute infections, chronic inflammation, cigarette smoking, exercise, stress, drugs, bone marrow stimulation by non-hematological malignancies, and heat stroke. Now coming to reactive neutrophilia. Going quickly over it, we all know that acute infections commonly cause various degrees of neutrophilia due to the release of the segmented neutrophils in bands from the bone marrow. They enter into the marginating pool, and that happens typically in bacterial infections, which may be pneumococcal, staphylococcal, leptospiral, etc. Viral infections like herpes, varicella, Epstein-Barr virus. Now, reactive neutrophilias are typically associated with toxic granules, dual bodies, and cytoplasmic vacuoles, and an elevated level of leukocyte alkaline phosphatase, or the LAP. Now, what is this leukemoid reaction? Leukemoid reaction denotes a pronounced neutrophilia in acute inflammatory conditions. Okay, a myeloid leukemoid reaction is defined as a peripheral blood count of WBCs which is more than 50,000 per cubic mm, or a differential count with more than 5% of immature myeloid cells capable of division, typically the metamyelocytes, myelocytes, and promyelocytes. Severe bacterial infections are associated with this reaction, but viral infections do not usually cause a myeloid leukemoid reaction. Disseminated fungal infections, however, can cause a mild to profound neutrophilia. What are the differential diagnoses, and how do you ascertain it? The differential diagnosis of a leukemoid reaction besides CML that we know of is also CNL. What is this? Now, CNL, chronic neutrophilic leukemia, has to be distinguished from a leukemoid reaction. Okay, it is important because patients present with neutrophilia. In addition, there is also a dysplasia with a very important mutation that is seen in about 89 to 100% of these cases. It's nothing but the CSF3R. Okay, that is the colony stimulating factor 3R. Now, cytogenetic and molecular studies should always rule out CML. There should not be any T922 or BCR-ABL transcript, and particularly no P230 BCR-ABL transcript, because this P230 BCR-ABL transcript is often associated with neutrophilias. Now coming to CML, we're keeping it simple because CML has a WBC count which is more than 1 lakh per microliter, usually. Okay, a WBC differential containing promyelocytes and metamyelocytes as well as myelocytes. So myelocyte peak is very important in CML. Okay, a low lap score, a large spleen, and above all, a Philadelphia chromosome. Now, when we sum it up, we have a leukemoid reaction which predominantly shows mature neutrophils with a marked left shift. Okay, whereas a CML shows, besides the immature cells, basophils as well as eosinophils. A chronic neutrophilic leukemia shows a marked neutrophilia. Bone marrow examination in a leukemoid reaction shows a myeloid hyperplasia, whereas it shows basophilia, eosinophilia, monocytosis, and increase in blasts in CML. It should be noted that HLA-DR, okay, is negative in case of leukemoid reaction, whereas it is positive in case of CML and CNL. Besides that, we also have the cytogenetic abnormalities like BCR-ABL in CML and CSF3R seen in 89 to 100% of the cases in CNL. Now, a very important thing for undergraduates as well as postgraduates is the neutrophil alkaline phosphatase, or NAP. Now, what is this NAP or LAP? It's also referred to as the leukocyte alkaline phosphatase. The alkaline phosphatase activity is found predominantly in mature neutrophils and metamyelocytes. Okay, so what is the principle and why is it needed? It is important because it differentiates CML from a leukemoid reaction. And the principle behind it is that the naphthyl ASB1 phosphate is hydrolyzed in the presence of LAP at an alkaline pH into the aryl naphthylamide. Okay, and this aryl naphthylamide that is generated is coupled with the fast blue. Okay, and what happens is that this fast blue converts it into an insoluble precipitate at the site of the enzymatic activity. So that is the basic principle behind it. And because this LAP enzyme is characteristically present in mature neutrophils and in metamyelocytes, it is important to note that the LAP score is very high in case of a leukemoid reaction, whereas it's low in case of a CML. Now, how do you score it? When it's no granules, it's 0. 1 plus shows occasional diffuse granules, moderate granularity is 2 plus, and strong positive is 3 plus, and confluently strong positive is 4 plus. The test was based on the principle that normal neutrophils, remember, would be very high in LAP. However, these abnormal neutrophils in CML, okay, as well as the immature forms, would have a low or deficient LAP. Scores of the LAP test can range from 0 to 400, and those between 20 to 100 are considered as normal. A score that's higher than the normal is obviously associated with a leukemoid reaction. How do we ascertain it? We can add up the scores. For example, if we count it for 100 cells, and 20 of such show 1 plus, 25 show 2 plus, 40 show 3 plus, and 15 show 4 plus, we can simply multiply and then subsequently sum it up, and a score of 20 to 100 is obviously normal. But however, this technique is comparatively very subjective. It's time consuming as well. So for that, we now use LAP assay by flow cytometry. Okay, we can do it on the EDTA samples, and that is very important. The LAP has not lost its significance, let me tell you that. Timely results can allow small hospitals to rule out CML, especially in a country like ours. Yes, it's very important. It can rule out CML before the outsourced molecular biology results are possible. So if you have to outsource a BCR-ABL transcript, you can better do a lab score and determine whether it's CML or not. So lab scoring by flow cytometry has sorted out things. A gating strategy is established to measure the lab score in the mature granulocytes. So we do a side scatter plot here with CD45 and finally find these granulocytes here and up there. Okay. And then what we do is that we again gate it to the CD16 urine and CD45 to ascertain these mature granulocytes urine. So ruling out from the rest, we have these mature granulocytes, okay, and these mature granulocytes can be subsequently gated again to find out the LAP positive extent on the histogram. These mature granulocytes can therefore help in ascertaining lab score by flow cytometry. So it's that simple, yeah? Chronic inflammation such as rheumatoid arthritis and Kawasaki disease as well as inflammatory bowel diseases can all cause neutrophilias. Neutrophilia in such conditions have been implicated because of the release of TNF-alpha, GM-CSF, GCSF in interleukin 6 and 8. Cigarette smoking has also been associated with neutrophilia. However, the mechanism of it is not very well known. We also have stress. Now, stress, what does that do? It releases hormones, okay, typically epinephrine. Now, what does epinephrine do? Epinephrine, what it does is that it redistributes the neutrophils from the marginating pool, okay, into the circulating pool. Once the neutrophils are moved on into the circulating pool, and that results in neutrophilia. Remember, epinephrines can also cause a decrease in the level of L-selectins. So a decrease in the L-selectin inhibits rolling, and that converts the neutrophils from the marginating pool into the circulating pool. Postoperative neutrophilia and leukocytosis during AMI is also associated with stress and subsequent release of cortisol and epinephrine. Exercise-induced neutrophilia is associated with a combination of increased plasma epinephrine levels and a change in the cardiac output, leading to redistribution of neutrophils from the marginating pool into the circulating pool. Now coming to sepsis. Now that is extremely important, right? We have severe inflammatory response syndrome, and this is a criteria. There are 4 things that we need to keep in mind. One is tachycardia with a heart rate of more than 90 beats per minute, a tachypnea with a respiratory rate of more than 20 breaths per minute, a fever or hypothermia, a leukocytosis, leukopenia or a bandemia with more than 10% bands. Okay, and patients who meet 2 or more of these criteria usually have SARS. So what is sepsis for that matter? Sepsis is a clinical syndrome defined by the presence of both infection and systemic inflammatory response. What is severe sepsis? Sepsis associated with organ dysfunction, hypoperfusion or hypotension, and a septic shock on the other hand is sepsis-induced hypotension despite adequate fluid resuscitation, along with the presence of perfusion abnormalities that includes but is not limited to lactic acidosis, oliguria, or an acute alteration even in the mental status. Multiple organ dysfunction syndrome is, however, associated with the presence of altered organ function in acutely ill patients, such as homeostasis cannot be maintained without any interventions. Now, Robbins and Cotran, we are very, very indebted to them, right? Because they define that microbial products, that is pathogen-associated molecular patterns, can stimulate the neutrophils and monocytes, and that results in activation of them, releasing cytokines and cytokine-like mediators like TNF and the interleukins. And subsequently, what happens is that the interleukin-1 is very important. It results in fever. In addition, the systemic effects like myocardial contractility, which is diminished, and metabolic abnormalities can all result in a multi-organ failure. What happens is that these endothelial cells, which are also activated, can either have a procoagulant effect or an antifibrinolytic effect, and that results in DIC, and subsequently tissue ischemia, all resulting in a multi-organ failure. Even activation of the complement cascade results in activation of these endothelium and subsequent destruction. In addition, what happens is that these interleukins have the propensity to cause vasodilatation, increased permeability, a decreased perfusion, and subsequently a multi-organ failure. So yes, we have decoded sepsis, right? So this is the pathway that is completely involved in sepsis. And these are the cytokines that are actually important for all of us to know. Now coming to primary neutrophilia, they may be hereditary. It may be a rare autosomal disorder characterized by chronic neutrophilia ranging from 20,000 to over 1 lakh. Okay, patients may have splenomegaly, but it's very important that the lab score is elevated. Okay, even though it has a splenomegaly here and a very high count, Okay, the lab score is elevated. On the other hand, we have transient myeloproliferative disorder in Down syndrome, also called as the transient abnormal myelopoiesis. Now, the defect here lies in the GATA1 gene. Now, what is this GATA1 gene? Now, this mutation in this GATA1 gene, which is implicated in megakaryocytic proliferation, is important because the blasts here usually are megakaryoplastic. It is important that this transient abnormal myelopoiesis or the transient myeloproliferative disorder seen in Down syndrome usually disappears spontaneously after 4 to 6 weeks or about 3 months. Okay, a small proportion, however, changes into an acute myeloid leukemia. So this is a very interesting case that we've come across. Now you have these cells here. Okay, what are these cells? Okay, what are these cells? Okay, with some sort of blebs here and there, and a basophilic cytoplasm. Okay, okay, here. It was just a 11-day-old child. Okay, who presented with splenomegaly, and this was the blood picture. And it was a case of transient abnormal myelopoiesis. And these are blasts, okay, with blebs and vacuoles in their cytoplasm, prominent nucleoli, yeah, prominent ones, yeah, and this is nothing but a TMD associated with Down syndrome. Yes, there was history of Down syndrome. Okay, now coming to the recent advances. The recent advances, that is the sputum neutrophils. Sputum neutrophils has gained an increasing interest by researchers in recent times because it's a predictive biomarker of severe asthma. The evaluation of sputum inflammatory patterns in patients with moderate to severe asthma showed that about 20% had higher percentage of sputum neutrophils. This sputum neutrophil shows an inverse correlation with forced expiratory volume 1 or the FEV1. Neutrophils are recruited and activated by interleukin 8, so therefore a greater expression of interleukin 8 mRNA and protein was found in the sputum of neutrophilic asthmatics. So all we have learned is that the sputum neutrophil can serve as an important biomarker to predict severe asthma. Now coming to the neutrophil function defects. Okay, neutrophil function defects, that is the leukocyte adhesion defects, can result in neutrophilias as well. The reason behind it is that it again causes a shift of the neutrophils from the marginating pool into the circulating pool. Now, these can either be type 1, type 2, or type 3. Okay, let's just go into it one by one. Now, LAD1. What is LAD1? That is leukocyte adhesion defect type 1. I hope you remember that beta-2 integrins, that is the CD18 or CD18-11B or 11A for that matter, are adhesion molecules that are present on the surface of neutrophils. Now remember the thing that we discussed in the last class, session 1? Okay, let me just show you the diagram. Look at this diagram, that makes things easier. Now coming to the integrins, as I said, these are all integrins here, okay, and these integrins bind to the integrin receptors on the surface of the endothelium. So these integrins expressed on the neutrophils bind to the integrin receptors, okay, expressed on the endothelium. A defect here, a defect in this integrin would therefore result in inhibition of this tight binding or firm adhesion, and that would result in a leukocyte adhesion defect type 1. Okay, so coming back here again, we have beta-2 integrins, okay, that can be CD11B or 11A, and they are expressed on the surface of the neutrophils. Now remember, they bind to the integrin receptors, that is the ICAM1 and the VCAM1, that are expressed on the surface of the endothelium, and that brings about the firm adhesion. So the classical adhesion deficiency that we talked about, that is the LAD1, is caused by a mutation in the gene that encodes the common beta-2 subunit of the integrin. In this disease, otherwise structurally normal neutrophils are not able to attach to the endothelium, and therefore they shift from the marginating pool into the circulating pool, resulting in a very high neutrophil count, and sometimes even prompting the physicians to consider that this would be a case of an infant leukemia for that matter. Now, children in this case usually present with a delayed separation of their umbilical cords, followed by a fatal omphalitis. More than 75% of children die before the age of 5 years if they do not receive a bone marrow transplantation. The severity of infections and complications is related to the severity of the CD18 deficiency. Cases with less than 1% expression are clinically very severe. Okay, whereas those with 2.5 to 10% expression of the beta-2 integrin are moderate to mild. LAD1 carriers have about 50% expression of CD18 and are clinically asymptomatic. The diagnosis is to be suspected when an infant presents with serious infections and a striking neutrophilia. The diagnosis can be confirmed by flow cytometric analysis of the peripheral blood neutrophils using monoclonal antibodies against CD11 or 18. It should be noted that leukocytes express CD18 at about 20 weeks of gestation, and therefore even chordocentesis can allow for a prenatal diagnosis of LAD1. Now coming to LAD2. Now LAD2 is a defect where there is a defect in rolling of the neutrophils. Okay, now rolling. Now rolling, remember the diagram here? Now rolling is implicated only when the Sil-Lewis X modified glycoprotein interacts with the E and the P selectins expressed on the surface of the endothelium. So what happens is that if there is an absence of the Sil-Lewis X modified glycoprotein, that is the ligand for the selectins here, there is a defect in the rolling. A defect in the rolling again allows for the movement of the neutrophils from the marginating pool into the circulating pool, and that results in neutrophilia. So there's a marked decrease in chemotaxis accompanied by a pronounced neutrophilia. Apart from the leukocyte defect, these patients also suffer from mental retardation, stunted growth, and a rare Bombay blood group. Okay, that is, as we all know, it's just the absence of the H antigen. Confirmation can be done by cell sorter analysis or flow cytometry involving CD50, which encodes the Sil-Lewis X modified glycoprotein. Now coming to LAD3. Now LAD3 is a LAD1 variant. Okay, it's a mild LAD phenotype and mild leukocyte adhesion defect. Why do I say mild? Because extensive studies have revealed that there is a mutation in the firm T3. Now what is this firm T3? Firm T3 is a gene that encodes for a hematopoietic structural protein called the kindlin-3. Okay, what is the function of this kindlin-3? The kindlin-3 acts as a switch to activate the integrins on the surface of the neutrophils. Okay, so if there's a defect in firm T3, there's a defect in the production of kindlin-3, and that cannot allow the switching on of the integrins. Hence, the integrins remain unactivated, and that these inactivated integrins cannot bind to the integrin receptors, and subsequently there is increased neutrophilia because the neutrophils move from the marginating pool to the circulating pool here. Yeah, we've all understood that. Now coming to the autosomal dominant hyper IgE syndrome. Now, autosomal dominant hyper IgE syndrome is a multi-system disorder characterized by an elevated level of IgE. There's a loss of function mutation in the signal transducer activator of transcription 3, and that leads to a loss in the production of T helper 17. Now remember, the last class that we discussed, the T helper 17 cells are basically implicated in the recruitment of neutrophils. So if there is a defect in T helper 17, the recruitment of neutrophils cannot happen. And in that case, there's a profound defect in the chemotaxis. Okay, so a defect in the chemotaxis results in neutrophilia. Now, who senses the danger in our body? Yes, we all know it's the toll-like receptor. The toll-like receptors are proteins that play a key role in the innate immune system. They are structural receptors, conserved molecules, and it is important to note that neutrophils express all the toll-like receptors except the TLR3 and 7. So this is urine. The diagram shown alongside is a TLR4, and it has what is important to note, the TIR domain. Okay, with an adaptive protein. It is important because it is essential for the signaling pathway. It plays a pivotal role in the production of the NF-kappa beta, and that subsequently allows for a downstream signaling pathway. The downstream signaling, remember, let's move on to the next slide. We have the pathogen-associated molecular patterns and disease or damage-associated molecular patterns. All can activate these toll-like receptors, which function via the MYD88, okay, and the IRAK4. Now, what is this IRAK4? IRAK4 is nothing but the interleukin-1 receptor-associated kinases. Now, what are the function of this? This IRAK4 and MYD88 are important because they allow for the production of NF-kappa beta and allow for the signaling via the MAPK and the mTOR pathway. There is production of pro-inflammatory and anti-inflammatory cytokines like interleukin-1 beta, 6, 12, TNF-alpha being pro-inflammatory, whereas interleukin-10 being anti-inflammatory. So neutrophils from children with recurrent pyogenic infections, especially the Streptococcus pneumoniae, caused by an inherited IRAK4 deficiency. In addition, inherited mutations in the genes encoding the MYD88 are also implicated in a similar phenotype. Now, what are the defects in the killing? We all know phagocytosis is the initial step which allows for the neutrophils to destroy the invading pathogens. Okay. It may be by the release of the granules or by formation of the neutrophil extracellular traps. Yeah. Now, coming to the very important condition, it's the chronic granulomatous disease. Now, this is the most frequent disorder of neutrophil function. In chronic granulomatous disease, the components of an enzyme complex named the NADPH oxidase is absent. Okay, yeah, and that leads to the inability to phagocytose the microorganisms. Remember the NADPH oxidase that we were talking about, okay, and the MPO halide system that we were talking about in the last class? Now, apart from the fulminant infections by bacteria and fungi, this also leads to a chronic and low inflammatory reaction characterized by granuloma formation. It even simulates Crohn's disease and sometimes even sarcoidosis, you know. So in the gut, the process is indistinguishable from Crohn's, and in the lungs, sometimes this condition mimics a sarcoidosis. Now, this is the NADPH oxidase. It has a plasma membrane component. It also has a cytoplasmic component. Okay, the membrane component has a very important subunit here, that is the GP91 FOX. What is the function of this? We'll be coming to that in just a bit. Now, we also have the P22 FOX in the membrane. In the cytoplasm, however, we have P47, P67, and P40 FOX. It is important to note that 2/3 cases of chronic granulomatous diseases are X-linked. Okay, and being X-linked, they are associated with a mutation in the GP91 FOX. Whereas about 1/3 of the cases have a defect in the GP47 FOX and 67 FOX, whereas GP22 FOX affects a minor percentage, that is about 5% of the cases. It is important to note that most of the cases, that is about 2/3, are X-linked recessive, whereas the rest, that is the 1/3, is autosomal recessive. A very important function is that of GP91 FOX, which encodes a membrane-bound subunit of the enzyme. Now, what is the function? Now, NADPH donates electrons, okay, which passes on within the GP91 FOX to the molecular oxygen here. Okay, so once you have this molecular oxygen, okay, that accepts the electron donated by the NADPH. It is passed on within the GP91 forks to the oxygen here to generate what is called as the superoxide. This superoxide spontaneously dismutates to form H2O2 or the hydrogen peroxide. This hydrogen peroxide subsequently in the presence of MPO changes into the halide. And it is this H2O2 MPO halide system which has been the most efficient system of bactericidal activity in neutrophils. So what are the clinical features? Most children with chronic granulomatous disease present in the first year of life with recurrent bacterial and fungal infections. The most frequently encountered pathogen may be Staph aureus, Aspergillus, and enteric gram-negative bacteria. One of the major hallmarks of this condition is, yes, the granulomas that we were talking about that often mimic Crohn's disease granuloma. Now the diagnosis. The bacterial killing test is a comprehensive screening test for the defects in the oxonization, phagocytosis, or intracellular killing. However, this test is very time consuming, and is also very subjective. So for that matter, we have nitro-blue tetrazolium test, very important test for the postgraduates to know. It's a test which is extremely easy and reliable to ascertain the disorders of oxidative metabolism. Neutrophils are exposed to a stimulus, that is the PMA, the four-ball, that is the myristate acetate, or the PMA for that matter, incubated with nitro-blue tetrazolium, or the NBT, and staining is assessed by counting around 100 neutrophils on a smear, similar to the lab that we did. After stimulation, more than 95% of the neutrophils from the healthy individuals must stain positive with a blue-black precipitate or forma zone. Now whereas when it is less than 5% of neutrophils staining with this, it happens in conditions that is the chronic granulomatous disease. Carriers of this X-linked chronic granulomatous disease usually show a 30 to 70% positive stain. The more sensitive quantitative tests have also come up. They use flow cytometric analysis to determine this nitro-blue tetrazolium activity in the neutrophil. Now, neutrophils are stimulated in vitro using reagents like PMA, and superoxide or hydrogen peroxide is generated, and that is what is measured. In one assay, even hydrogen peroxide generated by stimulated that is the GP91 or GP47, 67, 40 or 20 for that matter, is involved. So even the component that is implicated in the NADPH oxidase deficiency can be ascertained. Now coming to the MPO deficiency, we have the myeloperoxidase deficiency. Now this is a minor phagocyte intracellular killing defect. Yes, we know that MPO converts H2O2 to the halide. It is caused by a mutation in the MPO gene, which is expressed on chromosome number 17. Granulocytes with MPO deficiency have defective generation of the hypochlorite ion but have normal superoxide ion production. And hence the intracellular killing for that matter is just minimally affected. In some individuals, in vitro assays show slightly reduced killing by Staph aureus and sometimes even impaired killing of Candida albicans. Most patients with MPO deficiency are completely asymptomatic. The diagnosis is usually made by histochemical staining of the neutrophils, that is using the anti-MPO antibodies. Then we can also do the NBT test when it's quite close to chronic granulomatous disease. So what do we get in that case? We have a tetrazolium that is yellow in color. That in the presence of NADPH oxidase produces formazone, and that is blue in color. Now in chronic granulomatous disease, there's a mutation in the NADPH oxidase component, usually the GP91, which is seen in about 2/3 of the cases. Failure to generate the reactive oxygen species produces the NBT, and abnormal or remains yellow. However, in MPO, is most common cause of defective oxygen dependent killing. Failure to bleach and formation of H2O2 is not impaired. Okay, and in that case, what happens is that the patients usually present with symptoms that are similar to that of the chronic granulomatous disease. However, when we do the NBT test, there is a normal blue color that is produced, and that ascertains that the deficiency is in MPO and not in NADPH oxidase. Now, coming to the Shristi-Higashi syndrome. Now, the killing in neutrophils is impaired in patients with an abnormal formation of granule. This is the case of a Shristi-Higashi syndrome, where the mutation is in the LIST gene, okay, which encodes a protein that is involved in lysosomal trafficking. So this is very important, that the lysosomal trafficking is disturbed. One of the hallmarks of Shristi-Higashi syndrome is the presence of giant granules, okay, seen in neutrophils in a blood smear, reflecting the abnormal granule formation in these cells. However, neutrophil dysfunction in Shristi-Higashi syndrome is not a dominant feature. What is dominant is that patients usually present with a partial albinism, okay, but the abnormal function of cytotoxic T cells leads to an uncontrolled inflammatory response, and lethal hemophagocytosis, okay, is by far the most important feature of this disease. Now, what is this LIST protein? LIST protein is encoded by the CHS1 gene. What is the function of LIST protein? The defective formation of this protein results in uncontrolled granule fusion, and that results in what is referred to as large or giant granules, not only in neutrophils but also in the Schwann cells, melanosomes, etc. A deficiency of granules containing serotonin and ADP in platelets often results in a defective platelet aggregation and even a prolonged bleeding time. This is just a pictorial representation of this Shristi-Higashi syndrome. Yes, as I said, that there's a defect in the CHS1 gene, okay, which results in the LIST protein defect. Now, LIST protein is defective, therefore there is giant granules, okay, all resulting in functional defects. Even the platelets have lack of serotonin and ADP, and that results in defective platelets, resulting in easy bleeding or bruising. In addition, we also have recurrent infections because of these giant granules within the granulocytes, okay, all resulting in infections, which may be skin infections, respiratory or GI infections, and there may be defective granules even within the Schwann cells, resulting in peripheral neuropathies, seizures, weakness, gait disturbances, etc. Now, coming to the specific granule deficiency. Neutrophils, in case of specific granule deficiency, lack secondary and tertiary granules. Genes inactivating mutations in this case are the CEBPE, that is the SEPE gene, which have been implicated. The protein encoded by this gene plays an essential role in the formation of the granules in the myeloid cells. So a defect in the CEBPE gene results in granule deficiency. Usually the secondary and the tertiary granules are involved. We also have the glucose 6-phosphate dehydrogenase, that is G6PD deficiency. As we all know, it's been associated with severe hemolytic anemias, but besides that, G6PD is also associated with NADPH oxidase deficiency. Okay, so it produces a picture which clinically resembles a chronic granulomatous disease. So that is also to be kept in mind. So finally, we've come to a very interesting section. Okay, after discussing a lot of neutrophilia, neutropenias, and neutrophil function defects, okay, we have a very interesting thing here. We are decoding antibiotic resistance, and that too from a neutrophil perspective. Okay, from a neutrophil's perspective. Yes, let's move in. Now, bacteria have strategies to evade this neutrophil function, you know. Yes. Streptococcus pyogenes produces secreted peptidases known as the SCPA and SCPC. They degrade the C5a, that is the complement protein, C5a, and interleukin 8. Remember, these are chemoattractants. These are the chemoattractants. So these chemoattractants, once degraded, can cause a defect in the neutrophil function. Even the streptococcal organisms secrete esterases like the SSE, streptococcal secreted esterase, which inactivates the platelet activating factor. Remember, platelet activating factor is also a chemoattractant. Besides that, Streptococcus pneumoniae blocks the activity of the neutrophils by blocking its recruitment by producing enzymes like zinc metalloproteinases, which targets the initial rolling step of neutrophil extravasation by cleavage or the N-terminal domain of P-selectin glycoprotein 1. So remember that these P-selectins and the E-selectins are expressed on the surface of the endothelium. Okay, so these E-selectins are expressed here and the P-selectins on the surface of the platelets as well as on the endothelium. So what is the function of the selectin? The selectins are involved in the rolling. So this initial step of rolling is disturbed in case of Streptococcus pneumoniae. Staph aureus is one such very important pathogen because it blocks the neutrophil activation and chemotaxis by producing enzymes like chemotaxis inhibitory protein, or the CHIPs, which binds to the complement 5A receptor and thereby blocks its functioning. So if it blocks the C5A receptor, then what happens is that the neutrophils, even though recruited, cannot act on its site of action. Staphylococcal superantigen-like protein inhibit the TLR2, which is required for the recognition of the Staph aureus. In addition, SSL5 and SSL11, as well as the staphylococcal enterotoxins, inhibit the neutrophil extravasation by again blocking the P-selectin ligands expressed on the surface of the endothelium. Again, remember, blocking the rolling. Bordetella, what does that do? That stimulates the production of the anti-inflammatory interleukin 10, which in turn inhibits the neutrophil recruitment. Shigella, on the other hand, suppresses genes which are involved in chemotaxis, especially the interleukin 8. Okay, the interleukin 8, once affected, neutrophilic chemotaxis is impaired. High levels of PI5P, that is the phosphatidylinositol 5-phosphate, triggers ICAM1 internalization. Remember the ICAM1 that was expressed on the surface of the endothelium, that was implicated in the tight binding of firm adhesion. Okay, so if that is internalized, then what happens? Internalized and degraded, and therefore that affects the neutrophil traffic during infections. So remember this diagram that we were talking about. Here we have the Cy-Lewis X-modified glycoprotein. Here we have the high affinity integrins, okay, which binds to the ICAM1. Internalization of this ICAM1 allows for failure of this firm binding, and subsequent neutrophilic diapedesis and migration is defective. What about the evasion of phagocytosis? Now, receptors present on the neutrophil surface are the pathogen recognition receptors, or the TLRs. Okay, they are important because recognition of the invading microorganism. Phagocytosis is most efficient in the presence of opsonins. So opsonins were discussed in the last class as well. So that was IgG, complement 5B, 3A, etc. So what are they? They are directly involved in the opsonophagocytosis. Now IgG or IgM bound to the microbial surface is recognized by C1q. C1q further on activates the classical complement pathway. One of the most important things, or the primary mechanisms to prevent recognition, is through the masking of these surface epitopes, thereby preventing the binding of the antibodies and deposition of the complement on the bacterial surface. So masking of these epitopes results in prevention of activation of the complement cascade. There are many examples. Inhibiting neutrophil phagocytosis has been noted in Streptococcus, Neisseria, Klebsiella, E. coli, Pseudomonas, Haemophilus, etc. Bacterial pathogens also mask epitopes through structural modifications that prevent recognition by the pathogen recognition receptors, or the TLRs, present on the surface of the neutrophils. We also have several gram-negative bacteria like the Yersinia and Salmonella, okay, which modify the lipid A structure to inhibit the recognition by the TLR4 on the surface of the neutrophils. How about evading the bactericidal activity by NADPH oxidase? Yes, there are some bacteria which do that as well. Anaplasma phagocytophilum is one such obligate intracellular pathogen. Okay, it has the propensity to evade NADPH oxidase mediated killing. Anaplasma phagocytophilum does not elicit a pronounced increase in the intracellular reactive oxygen species. It rather inhibits the delivery of the GB91 FOX. Remember the GB91 FOX in chronic granulomatous disease that we were talking about? Yes, it is the same GB91 FOX of the NADPH oxidase, okay, which is inhibited. Inhibiting it results in improper formation of the phagolysosomal or vacuolar membrane, and as a result of which there is evasion of the bactericidal activity. In addition, even Francisella tularensis also excludes the GB91 FOX from the neutrophil phagosome, resulting in pronounced inhibition of reactive oxygen species or the MPO halide system activation. Further on, we also have nets. Now, nets were exclusively discussed in the last class, right? So, nets have the potential to augment the innate host defense. Few bacterial organisms produce nucleases, remember, that can destroy the cell-free DNA that forms these neutrophilic extracellular traps or the nets. What about the evasion of the neutrophil apoptosis? Now, neutrophilic apoptosis is also evaded, okay, by organisms like Anaplasma phagocytophilum and Chlamydia pneumoniae. The delay of neutrophilic apoptosis is mediated partly by an increased MAPK kinase and partly by an increase in the PI3-AKT-mTOR pathway. Okay, similar to that which is seen in all of the other carcinomas as well. So in a steady state condition, must remember that aged neutrophils undergo apoptosis, okay, and that is destined to happen. A delay, which may be due to a defect or a mutation that may be caused, okay, so the delay in case of an infection by Anaplasma phagocytophilum or Chlamydia may result in an increase in the phosphorylation of the PI3K-AKT-mTOR pathway or the MAPK kinase pathway. Apoptosis is also affected in Francisella tularensis. Now, what does that do? This is another intracellular bacterial pathogen that delays neutrophil apoptosis by affecting the BCL2 family protein. Namely, the pathogen impairs the processing and activation of caspase 8, okay, and the BID, and significantly inhibits apoptosis by impairing translocation of the Bax-G. Okay, that is the mitochondrial pathway of apoptosis shown alongside is disrupted completely. So a disruption or an anti-apoptotic effect may be produced. Now coming to the induction of premature apoptosis. Now induction of premature apoptosis happens in conditions like E. coli, Pseudomonas aeruginosa, Staph aureus, etc. Now Pseudomonas aeruginosa secretes a phenothiazine exotoxin. What is the function of this phenothiazine exotoxin? That allows for apoptosis or phagocytosis. In addition, we also have the Pseudomonas aeruginosa, which secretes a phenothiazine exotoxin called as a pyocyanin that rapidly accelerates the neutrophilic apoptosis. So one was an evasion and the other is allowing for accelerated neutrophilic apoptosis. Now, why is this causing harm then? Okay, this is because accelerated neutrophil apoptosis, that is not the aged neutrophils we are talking about. We're talking about the new ones. Okay, that is the budding neutrophils. Okay, these budding neutrophils are destroyed by Pseudomonas aeruginosa. Now, pyocyanin-induced apoptosis is a ROS, that is a reactive oxygen species dependent process that mediates dysfunction of the phagosome and leads to a release of cathepsin. permeabilization of the mitochondrial membrane. We also have some ingested Staph aureus, etc., which can also cause a dissemination of the viable bacteria by destroying or prematurely destroying rather the neutrophils. Okay, so premature destruction of the neutrophils, okay, who have ingested the Staph aureus can lead to dissemination of the viable bacteria and thus perpetuate the disease process. Okay, so eventually, yeah, it was a very long seminar, I agree completely. Yeah, so what are the key takeaways from this seminar? Defects in the neutrophil quantity, adherence, chemotaxis, and killing all lead to severe and potentially life-threatening diseases. Neutrophils are not that simple, right? The ones that we see in the peripheral smear every day in and day out. Yeah. Dissecting the molecular pathology of disorders of neutrophil function given us a unique insight into the primary means by establishing of what confronts pathogens, that is the innate immune system. Once recruited, neutrophils have a wide range of toxic mechanisms to fight any invading microorganism. When infections occur too frequently and severely impair the quality of life, support for neutrophil development is essential, and that is done by GCSF. However, high GCSF doses can predispose to AML. So careful monitoring of genetic changes may help to define the right moment for hematopoietic stem cell transplantation. During fulminant infections that do not respond to antibiotics or antifungals, transfusion of donor neutrophils can be a very good option. Many bacterial species, where the primary pathogens or commensals for that matter have the capacity to produce immune evasion molecules. As we all discussed, they evade completely the bactericidal process, phagocytosis, apoptosis, etc., everything. So there is a diverse array of bacterial immune evasion molecule that exists. In this era of increasing antibiotic resistance, especially among the commensals, the opportunistic pathogens, alternative therapeutic and or vaccines are need of the hour. Therefore, targeting bacterial immune evasion molecule could be one such approach. Thank you so much for your patient hearing. Thank you.
Thank you so much for this wonderful lecture. Excellently done. Just if you can just stop sharing so that we can see you.
Yes, sir.
Great. You can just put your video on if you want to. Brilliant. Excellent. In fact, indeed, neutrophils, as they appear on the peripheral smear, are not those so simple. You are absolutely right. So many adhesion molecules on the way, and the animations and the pictorial things which you have used are wonderful. It
Thank you
speaks
so much.
great about your concept and the way, the depth you have gone into this whole system. Wonderfully done, Dr. Shristi.
Thank
Brilliant.
you so much, sir.
I don't think so. I've heard anybody speaking better on this topic up till now. Wonderfully done.
Thank you so much, sir. It's an honor, sir, to be a part of
It's
this
an honor
course.
for the platform to have you here to speak on this topic. And since these are getting recorded, it will be a huge help for everybody across the globe who will be going through this, learning from this. And thank you for sharing the PDF in advance. We have already uploaded that on the Google Drive. Dr. Manoj Gupta says wonderful presentation. I agree with him 100%.
Thank you, sir. Thank you so much.
Wonderfully done. We are looking forward for the next lecture. I think that is on the 13th. Is that right?
Yes, sir.
So, right till then, thank you, Dr. Shristi. God bless you. Wonderfully done. Brilliant. Excellent. Take care. Bye-bye.
Thank you so much, sir. Thank you, sir.
Bye. Night.
Bye-bye. Good night.